I'll be focusing on the acute endophthalmitis, and what interests us all is the post-operative one following cataract surgery. So as we can see, we can have a spectrum of disease wherein we have this very evident hypopion, very evident retroventricular exudation. But we must not forget that we can have a very small little streak hypopion, and we may miss this unless until we do a very good examination on the slit lamp and look for this streak hypopion, because this little streak hypopion, the patient's vision might be good, the inflammation or the congestion may be very less, and yet your patient may tell you that I'm not seeing that well. So there is that streak hypopion that you should not miss. There's nothing in the pupil, it's absolutely clear, the lens seems to be fine, but after you dilate, you see that there is vitritis. So there can be a spectrum of disease, and this is just not endophthalmitis. Even a little streak hypopion is endophthalmitis. So day one. This is day one horror story, and of course none of us want this kind of picture to be seen the very first day after we finished cataract surgery.
Shalabh, there's a small window up there. Can you close that?
So it's not very clear. Can you have the lights a little low in the hall? Because they're all not very clear. So let me just take a little poll, okay? How many of us in our routine cataract practice use 10% povidone iodine for painting the skin? How many? Okay, so we do have a good number. So that is actually the correct percentage of povidone iodine that must be used to paint the skin. Secondly, how many of us actually scrub the lid margin? I hope all of you do, because it should not be retrospective. We must remember that just painting the skin is not enough. We have to scrub the lid margin, and as was said by Dr. Subhash, it's not necessary that you have to trim the eyelids, the lashes at all. And then the third one is, how many of us, after we drape the eye and put the speculum, flush the eye with povidone iodine? And again, please remember that 5% is recommended, but now more and more people are using 10% betadine to flush the eye. Okay? Again, we must remember that most of us, when we think about endophthalmitis, we think of the EVS that was done many years ago, and what they found at that time was predominance of the gram-positive organisms in their study. But in India, it's very different. We have more of gram-negative than gram-positive, and a very high percentage of the endophthalmitis where we have these isolates growing are mixed infection. So it's just not gram-positive or gram-negative bacteria, it is also fungi which is grown, and that is why we must, whenever we see a patient of endophthalmitis, we must think that whether this patient may also have a mixed infection. So let's come to the medical management. So the first question that I want to ask is there a medical management for endophthalmitis? Can we just give some medicines and the patient is cured? No. There is no medical management for endophthalmitis. What is there? It's just one part of the treatment. So your medical management is actually a supportive therapy for the intravitreal injection. We must remember that a patient of endophthalmitis, as soon as you suspect a patient of endophthalmitis, so that in the era of patients suing us, monitor the patient, admit your patient, watch very closely, which means you could also watch the patient hourly. Be gentle, be kind, and most importantly, be truthful. Many anterior segment surgeons, many of us, we want to think, अरे नहीं यार, हमारे patient में endophthalmitis नहीं होता है, अरे हमारे OT में endophthalmitis नहीं होता है. That is the kind of thing that you must not carry in your heart or in your mind. You must be truthful to your patient. And as was taught to us while we were doing IMS, as soon as we saw a patient of endophthalmitis in our OPTs, if the patient came, the time was noted. If the injection was not given within 1 hour, our HOD used to, literally thrash us. So that was how important the importance of intravitreal injection was given. It's not कि हाँ अच्छा patient सुबह में आया शाम में दे दिया, नहीं. The patient must be administered the intravitreal injection as soon as possible. Yes, there is medication in support of your therapy, and as soon as you see your patient, you can start off with fortified antibiotics, amikacin, tobramycin, cefazolin, or the 4th generation fluoroquinolones, moxi, gatifloxacin. You also have now the high strength gatifloxacin, atropine to dilate the pupil. The patients, because of the congestion, the pupil may not dilate that adequately with just cyclopentolate or tropicamide. You can start oral antibiotics, ciprofloxacin, or I use levofloxacin, analgesics. And of course, there's a trial which was done by Dr. T.P. Das where he used infusion, IV ciprofloxacin, and he proved that the concentration of intravitreal ciprofloxacin was enough if given intravenously, which means the MIC level was reached to kill the organism. Supportive therapy. I would like to start steroids after giving the intravitreal injection. Okay, so what many of us do is we see a congested eye, there is some fibrinous exudation, a streak hypopyon. We start off the steroids immediately. Now, the difluprednate instead of prednisolone is most favored by most of the anterior segment surgeons. But remember that the steroids must be started after you have given the intravitreal antibiotics. Topical can also include voriconazole if you are suspecting the fungal. And oral, again, the steroids can be started only after you have administered the intravitreal injection. Also the antifungal. So as I have been trying to stress is that the intravitreal injection of antibiotics and antifungals is the mainstay of treatment, and you must not delay giving that most important therapy for your patient of endophthalmitis. Procedure again must be done in the OT. You must be properly dressed and draped and prepared just like you are doing a proper surgery. Don't think that infection हो गया चलो हम कैसे दे देते हैं, नहीं. You cannot do that. Even people nowadays are just wearing their gloves. Avastin de diya. No, don't do that. Don't increase the risk for the patient. That is the eye of a patient, of a human being. We would not want our eye to be injected like that. So why do it for our patient? Just because he has infection doesn't mean that he does not need the proper procedure that needs to be followed for giving the intravitreal injection. Because that might, in many of our patients, the intravitreal injection is all that is required and the patient is cured. Again, as it has been stressed, prepare the injection yourself. Don't tell your staff, chalo dilution bana main aa raha hu. Nahin. He cannot do it.
Shalabh, we have a lot of overseas delegates. They may not understand your Hindi.
Okay, sorry. So don't tell your staff that you go and prepare the injection. Okay? You must do it yourself. And all of us ARS members, we received a chart which was made by Cipla and was sent by Dr. Lalit Verma from the ARS office to all of us. How many of us actually have that chart in our OTs? How many of us? Very few. What did you do with that chart? You probably threw it away. But that's not what is required. The chart was sent to you. Even I don't remember. Being a vitreoretinal surgeon, I don't want to remember. That chart is there in my OT, in my anterior segment OT, in my posterior segment OT. I don't want to remember because I may forget. I may not do the correct dilution. So that chart, please go back, or you tell the Cipla person here, get the chart, prepare the injection yourself, looking at the chart. And all the injections are there. Voriconazole is there, vancomycin is there, ceftazidime is there, amikacin is there. So make sure that we do the preparation of the injection ourselves. Taking the injection, changing the needle, getting the accurate dosing, very, very important. So one of the main reasons why we have endophthalmitis is poor wound construction. Now have a look at this wound. The iris just pops out. Actually, the wound, the SICS wound here was not stable. No? This is the ACIOL that has been placed after an eventful cataract surgery, and I've sutured. I've taken a suture. Actually, the patient just had 3 sutures. So after having a PC rent, ACIOL was put, but the wound was not secured. So we must remember that when we have a complication, or even when we don't have a complication, the most important thing is the wound must be secured. Especially when we do SICS. SICS has been done, the wound is gaping open. So you allow the infective organisms to enter the eye because your wound is not secure. Then here, endophthalmitis, and what we can see is that the wound is not stable. You have a little iris prolapse here. So the most important thing in preventing endophthalmitis is make sure that your wound is stable, nothing can go in and out. We don't want organisms entering and going and causing the endophthalmitis. See here, this is a PC rent, a phakia, and because the vitreous is in the wound, the patient has endophthalmitis. This 3-port vitrectomy. I'm just trying to show you this little strand of vitreous that is incarcerated in the wound, the SICS wound, and is the reason for it provides a tract for the organisms to enter inside the eye. Measure, as I just showed you, measure, always measure 3.5 millimeters from the limbus, always. And very slowly, using a 30 gauge needle, inject your antibiotics. This is a patient that had endophthalmitis the very first day. So you can see that there was an air bubble in the anterior chamber. Now why was the air bubble there? Because most probably the wound was not secure. And the surgeon thought that maybe I'll put an air bubble and that will close the wound. But that didn't. So patient had undergone phacoemulsification. Now let you look at this corneal edema coming up. Because of the edema, the wound has now closed, there is no egress, but when you inject your antibiotic, make sure that you are able to achieve a normal intraocular pressure. So you may depress the wound to allow some fluid to leak out, otherwise you'll have a very tight eyeball and have problems because of that. You may have the central retinal artery occlusion because of very high intraocular pressure. Small things that you must pay attention to. Okay, this is a patient which seems to have a very severe endophthalmitis. There is a dense membrane in the anterior chamber. When you give an intravitreal antibiotic, you must also take care of the anterior chamber before you give the antibiotic. So I showed you that this patient here had a little hypopyon. Here there is such a dense membrane that I did not just want to give an intravitreal antibiotic. So I went in using viscoelastic, dissected this thick fibrinous membrane. This is a Sinski hook, and I'm trying to remove this very dense membrane from the anterior chamber, making sure that all of it comes out. Okay, so I'm taking care to make sure that all of it is first released. and then using McPherson's forceps, I'm gently pulling out this membrane, and it comes out in one piece. Again, measure, 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 and then give your intravitreal antibiotics or with antifungal. So that is most important. You must always measure. And again, when to refer. Again, very important, because all of us as referral surgeons want our colleagues who refer the patients to us to give the intravitreal injection before you send the patient. As Dr. Kashyap said, give the intravitreal injection and then refer your patient. But you must know when to refer. So if there is improvement, which means that there is disappearance of the hypopion, there's a well-dilated pupil, and there's a presence of orange glow, observe closely. And you may inject the same intravitreal agent because your patient actually improved with that treatment. If there is deterioration, you see this very dense retrolenticular exudation, you have to refer because this will not get all right on its own. So if the hypopion is the same or increased, the pupil doesn't dilate, if exudates are seen behind the lens, you can refer. If VR support is not available nearby, you can choose to change the intravitreal agent. You might use, if you've used vancomycin with ceftazidime, you might want to use amikacin with vancomycin. Or you might want to add voriconazole to your intravitreal, the cocktail of drugs that you do inject. And generally, don't wait for the culture report. And many of us do get negative culture, no organism grown. Usually, because we don't actually send the sample to a good lab that is prepared to actually get that organism from that minuscule 0.1 ml that you have sent to him. Most labs, if you just find out what kind of plates are you going to culture the organisms for, many of you tell you liquid media or this particular one little plate. No, they must be. You must tell them these are the various plates. These are the various agents on which I want you to grow the organism. And as Pooja said, as a rule, do indirect ophthalmoscopy in all your patients of endophthalmitis. Many of us use just a direct ophthalmoscope. No, use an indirect ophthalmoscope. And if the patient has trauma, you may pick up the intraocular foreign body, which you may not with just a direct ophthalmoscope. And you can have a very favorable outcome. This is pre-treatment with just the intravitreal injection, post-treatment, again here, hypopion, corneal edema, and just with the intravitreal treatment, you can cure your patient. So, again, the intravitreal agent is the mainstay of therapy of endophthalmitis. Vitrectomy comes later. Thank you.
Thank you, Shalabh.